Hello everyone. Thank you for joining us today for our official launch of the Health IT eLearning Center. Today's presenter is Bruce Mackey. My name is Liz Jones and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question, please type it into the questions box in your GoToWebinar interface. We will take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's presentation on our website, www.mceda.org, and a copy of today's slides are available there now, as well as within the GoToWebinar interface. Housed within Alterum Institute, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of ARA, and more specifically the HITECH Act, MCEDA is Michigan's regional extension center, tasked by the federal and state governments with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted over 5,700 providers across Michigan, impacting 1.6 million patients annually. 1 out of 4 Michigan providers paid a meaningful use incentive payment did so under MCEDA's expert guidance. Ranked as the 5th largest REC out of an original network of 62, we are now also funded by the state of Michigan to assist providers in the Medicaid EHR incentive program. MCEDA's health IT services include, number 1, meaningful use support at any stage and year. We are here to support providers in either the Medicare or Medicaid EHR incentive programs, but providers participating in the Medicaid program also benefit greatly by qualifying for state-subsidized services. As a result of the recently announced Modified Stage 2 2015 changes, MCEDA has developed a streamlined service for Medicare-eligible professionals. The MCS Express service provides targeted technical assistance on these changes, an assessment of your current state, and, if eligible, the remaining steps to prepare for 2015 attestation. Number 2, security risk assessment, which is an embedded service within our meaningful use support. But if providers have meaningful use handled and only need assistance with the SRA, we offer it separately as a standalone service. Number 3, attestation and audit preparation. If you are getting ready to attest to meaningful use and just need some peace of mind that you have crossed all the T's and dotted all the I's, or if you are one of the many folks who have been selected for a meaningful use audit and need assistance responding, we are here to help. Number 4, targeted process optimization, or TPO, takes a stripped-down version of lean principles and applies them to any clinical or operational practice improvement initiative. No matter what you need help with improving in your practice or clinic, we have experts on hand who can assist you. Number 5, we have recently added a new service line supporting providers in the PQRS program. If you need assistance getting started in this program, or even if you have been participating but need some help with measure selection and reporting options, please give us a call to discuss a quote for services. And number 6, the Great Lakes Practice Transformation Network offers no-cost technical assistance to eligible providers in support of quality improvement initiatives, PQRS support, and preparing for the upcoming advanced payment model changes under macro MIPS. Contact us to learn more. In today's presentation, we will set the stage, discussing some of the alarming national and state statistics regarding hypertension and diabetes. From there, we will move into the heart of today's presentation, demonstrating the new Health IT eLearning Center, the Health IT patient management model, and touching on a few strategies and tools you can use to leverage your Health IT to identify diagnosed and undiagnosed patients who need help, engage patients as well as healthcare teams, monitor patient symptoms and leading indicators, analyze patient and population health improvements, and improve the health of your patients. Finally, we will have some time at the end of the presentation for some Q&A. With that, I will go over to Bruce.
Thank you, Liz, and thank you everyone for joining us today. So no one can argue against heart disease and stroke being immense issues in the United States. They're currently the first and fourth leading causes of death in the U.S. More than 2 million heart attacks and strokes happen in the United States each year, leading to over 800,000 deaths. They are the leading cause of preventable death in people under 65 years of age. And approximately 1 out of every $6 spent on healthcare in the U.S. is spent treating victims of heart disease and stroke. They are also the greatest contributors to racial disparities in life expectancy. Approximately 82% of hypertensive adults are aware of their condition, and 75% of them are on antihypertensive medication. Yet only 53% have their condition controlled to target levels. A staggering number, approximately 16% of Michigan's adult population have uncontrolled hypertension. Taking a look at the numbers around diabetes, a staggering 29.1 million people, or 9.3% of the population, have diabetes. That is nearly 1 in 10. Diabetes was the 7th leading cause of death in the U.S. in 2010. It was listed as the primary cause of kidney failure in 44% of all new cases in 2011. And in 2011, an estimated 10% of Michigan adults were diagnosed with diabetes. An additional 250,000 residents in Michigan are thought to have undiagnosed diabetes, and we're here today to help put a dent in those terrible numbers. One way we're tackling the problems before us is by creating the Health IT eLearning Center, a repository of recorded past educational webinars and helpful tools designed to assist healthcare providers and their teams leverage their existing health IT to identify and manage hypertension and diabetes. I'm going to jump over to the actual website now at www.hiteLearningCenter.org to give you a quick tour before coming back to these slides. So here on the home page, you'll find some general information about MCEDA, as well as a link here to information regarding the Million Hearts Initiative. These other 3 boxes, the quality improvement, disease management, and e-learning, also have links above in the menu. The quality improvement page has information regarding why providers and their teams need this information right now, today, and includes some high-level information regarding the pending payment model shift to focus reimbursements on the quality of care being delivered. These coming changes fall under MACRA or MIPS and will require providers to demonstrate that they're taking quality care of their patients in order to maintain reimbursement levels, or potentially get an increase to over 100% of the current reimbursement rate for top performers. Under disease management, we start to dive into hypertension and diabetes-related information, and also introduce you to the Health IT patient management model, a framework for leveraging Health IT to assist in the identification, engagement, monitoring, analysis, and improvement of your hypertensive and diabetic patients. This model and the corresponding education and tools developed around it was originally created last year and delivered to the public through a series of webinars presented between April and July of 2015. I know some of today's attendees tuned into that series, so much of what you'll see today will be a refresher as the eLearning Center brings those recordings and tools to you again in a concise, easily accessible format. The eLearning page is where you will find all of these educational materials. There are 4 webinars currently posted. The first in the series is an overview of the many things providers and their teams can do to leverage Health IT to identify, engage, monitor, analyze, and improve the health of their hypertensive and diabetic patients. This overview provides a little bit of everything, as it merely introduces the various topics, but doesn't get very deep into any of them. The next 3 webinars are deeper dives into various strategies and best practices, with one focusing solely on identification, one that focuses on engaging and monitoring patients, and finally, a webinar devoted to analyzing data and using the results to make additional improvements. Okay, let's jump back to the slides. We'll spend the rest of the time today discussing a few of the concepts and strategies contained within the webinars, including how the companion toolkit can help. There is close to 4 hours of recorded information posted here, So given our limited time today, I will obviously only be scratching the surface when it comes to the education contained within. Here again is the foundational framework this educational series was built from, the Health IT Patient Management Model. In the following slides, I'll touch briefly on each of these sections. As odd as this sounds, one of the often overlooked elements needed to properly identify hypertension is capturing accurate blood pressure readings. It's basic, and no doubt many of your staff will roll their eyes when you let them know about it, but you would do well to take the time to hold the blood pressure index to ensure staff is properly trained and everyone is taking blood pressure readings in the same accurate way. You may be surprised to find out how many of your staff need coaching in this very basic skill. Over time, poor habits form and skills drift. To identify hypertension and effectively manage these patients, you have to be able to rely on these readings. To effectively leverage your health IT, you need your lab results in as structured data. In my humble opinion, CMS did the industry a disservice by recently removing electronic lab results as a separate meaningful use measure. A lab interface is of course the best way to accomplish getting this information entered as structured data, but if that's not possible, manually key in those lab values. Most EHRs will allow you to manually enter lab results into the field designed to hold that specific data. And remember, if it's not structured data, you cannot easily analyze and report on the results. Interoperability, or the electronic sharing of information between health IT systems, is at the core of the Meaningful Use program and is a vital component needed to identify your hypertensive and diabetic patients. To get a complete picture of the patient, you also need to know what other healthcare providers know. To do this effectively and efficiently, you need to be able to exchange patient information using your EHR's embedded direct or peer-to-peer technology, or better yet, use one of several health information exchanges, or HIEs, to act as a middleman in the data exchange. Now that you have accurate structured data, you can use it for more than just documentation. It can be intelligently filtered and presented at appropriate times to enhance patient care. This is clinical decision support. A key part of the definition listed here is healthcare team. CDS is not limited to the physician, but can apply to extenders, medical assistants, other support staff, and even the patient. When you think of CDS, pop-up alerts are often the first thing that comes to mind. Decision support exists in many other forms, some of which you see listed here, ranging from red text on an abnormal lab result to diagnostic support. Some can be set and will happen without any extra work on the part of the provider, like red text on labs or medication interaction alerts when two incompatible medications are prescribed. Others require action on the part of the clinician or an administrator. For example, here you see lists of risk factors for hypertension and diabetes. CDS can be used to run reports on your active patient panel and identify those with modifiable risk factors who might best benefit from prevention. Targeted communication to your obese patients can provide them with treatment information, invitations to group visits, and referrals to a dietitian or weight loss center. At the visit, decision support can be implemented to provide information on smoking cessation options, community exercise programs, or DASH diet instructions for your hypertensive patients. Here you're introduced to one of the tools in the companion toolkit of the eLearning Center. The Hypertension Control Change Package for clinicians presents a listing of process improvements that ambulatory clinical settings can implement as they seek optimal hypertension control. It is composed of change concepts, change ideas, evidence or practice-based tools, and resources. There is a wealth of information contained here, and I highly recommend checking it out. Page 5 of the guide includes links to videos and assessment tools to measure staff blood pressure skills and retrain as needed. Accompanying the information in the change package is a tool authored by the Michigan Department of Health and Human Services for the proper measurement of blood pressure. This is also in the toolkit on the Health IT eLearning Center. Tackling CDS rules, there are two tools posted to the eLearning Center from healthit.gov that I know you'll find helpful. The detailed ambulatory CDS QI worksheet is a fantastic tool for planning, developing, and implementing CDS interventions. Even better, the tool is packed with some very helpful hypertension examples. Likewise, the Diabetes CDS Toolkit is a starter kit for diabetes follow-up care with examples that can help you consider how different CDS interventions can match work processes. If all team members are properly using structured data fields, you can use the wealth of data already in your patient database to help you find undiagnosed and at-risk patients. Imagine the impact you can have in the health of your patients if you can massage the data you've already collected to help you find undiagnosed patients. If they're undiagnosed, they're obviously not receiving the care they need. Mine your existing patient data and you'll likely find patients in need. A basic way to do this is through simple trending of blood pressure readings, looking for elevated BPs without a corresponding diagnosis. You can also take a look at your at-risk population by examining additional risk factors already on record. Have you adequately screened all patients with known associated risk factors to see if they're diabetic or hypertensive? We'll focus next on a protocol you can incorporate today to find undiagnosed diabetic patients by examining the relationship between diagnosis, medications, and lab results. This is a powerful workflow that could have a huge impact in your practice, and it simply involves analyzing and comparing the patient data you've already collected. This protocol was developed from a study published in 2014. The researchers looked at 11.5 million U.S. primary care records, comparing the relationships between diagnosis, medications, and labs. Through this analysis, they identified a list of over 63,000 undiagnosed diabetics. This slide summarizes the steps they took to extract this list of patients. MCEDA took this information and created a protocol that mimics these steps. By following this same protocol in your practice, you're likely to find some undiagnosed diabetics in your own patient panel. This protocol, which you'll find in the toolkit, can be used retrospectively on your existing patient database to find those who have been missed, and can also be applied to each individual patient visit as well to aid in accurate, timely diagnosis. This protocol also includes a check for prediabetes, which is obviously helpful, as you can use that information to prevent patients from transitioning all the way to type 2 diabetes. Similar to the diabetes protocol, the undiagnosed hypertension identification protocol should be used to identify undiagnosed patients in your current panel doing retrospective data analysis, and perhaps incorporate it into your daily patient flow to ensure no more patients slip through the cracks. Yet another great tool offered, the AACE and ACE Comprehensive Type 2 Diabetes Treatment Algorithm, represents the official position of the American Association of Clinical Endocrinologists and the American College of Endocrinology for the treatment of type 2 diabetes. When the MCEDA Undiagnosed Diabetes Identification Protocol references a management tool, this is it. Patient self-monitoring of blood pressure, or SMBP, is a valuable addition to the management and monitoring of hypertension. It is supported by the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, the American Heart Association, and the American Society of Hypertension. SMBP is especially useful for patients with poorly controlled hypertension. It can be used to titrate medications, improve control, and screen for white coat hypertension. Due to issues with office measurements, home readings may be an equal or sometimes better predictor of cardiovascular risk than office readings. This is exactly why we've encouraged clinical staff BP measurement retraining in a few other sections of this educational series. Self-monitoring should also be used to engage, enable, and motivate patient participation in managing a condition that is often asymptomatic. When implementing SMBP in your practice, you may find it beneficial to designate a staff member to manage the education, support, and possibly the initial review of logs. Whenever possible, patients should be trained using their own equipment, which also provides you an opportunity to validate or calibrate their BP monitor for accuracy. For ease of access for patients and staff, maintain educational materials in your EHR as well as the patient portal. You will also see greater overall success in your home monitoring initiative by standardizing protocols that are captured within your EHR and by engaging these patients through support groups. Other tools available in the companion toolkit are a couple of best practice guides for implementing SMBP in your office, one being a great action guide from the Million Hearts Initiative and a condensed 2-page provider guide for implementing an SMBP program at the office level. One great health IT tool that can be used to facilitate communication between the patient, provider, and care team is the patient portal. Patient portals can provide secure messaging, which can also be used by patients to submit their SMBP results electronically and with greater frequency than traditional paper logs. Patient portals also give patients access to results, education, and key information within their own medical record. Just making a portal available to patients will not ensure that they will use it. The portal must be engaging and user-friendly and must support patient-centered outcomes. The portal also must be integrated into clinical encounters so the care team uses it to convey information, communicate with patients, and support self-care and decision-making as indicated. Practices have used their portals to successfully serve a wide range of patients, including those who are older, have lower incomes, or are chronically ill. Patients are likely to use a portal when it is recommended by their providers and has functionality that supports patient activation. Portal training and technical support will help patients to make the most of its tools and services. One of the most basic ways to monitor the care of your diabetic and hypertensive patients is through the tracking and trending of associated clinical quality measures, or CQMs. Reporting on CQMs is a requirement of various programs like Meaningful Use, PQRS, and ACOs. There are several CQMs related to diabetes and hypertension, but the two most heavily promoted, and subsequently the two you're heavily encouraged to use, are NQF-18, controlling high blood pressure, which gives you the percentage of hypertensive patients who have their blood pressure under control, and NQF-59, comprehensive diabetes care, which looks to identify diabetic patients who have poorly controlled A1C levels or no recent result on record. Analyzing these CQMs will help you to determine how effective you've been in managing these disease states and improving outcomes. If you're doing well, you'll have a high or at least increasing percentage on NQF-18, and you'll have a low or at least decreasing percentage on NQF-59. Here we offer you a tool to assist in CQM selection. This tool lists the 64 CQMs approved for the Meaningful Use program with columns for listing those offered by your EHR, CQMs related to the Million Hearts program, as well as the measures you're encouraged to report on by both the Michigan Department of Health and Human Services and CMS. Identifying opportunities for improvement requires sound data analysis. Data analysis is taking raw data and converting it into useful information for decision making. In other words, taking the raw data you've collected in your EHR and asking, what does this mean? Can it be used to trend blood pressures or identify at-risk populations? The model for improvement, developed by Institute for Healthcare Improvement and discussed in the webinars, is a simple yet powerful tool for accelerating positive change. The model has two parts. The first part consists of three fundamental questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? The answers to these questions aids in setting aims, establishing measures, selecting the change to be implemented, and testing its effectiveness. The Plan, Do, Study, Act, or PDSA cycle is shorthand for testing a change by planning it, trying it, observing the results, and acting on what is learned. This is the scientific method used for action-oriented learning. There are many ways to help analyze the data and improve the health of your patients. The final products of some of these processes of improvement can include the creation and updating of practice protocols and policies, creating and updating order sets, incorporating algorithms or clinical pathways for treatment, and monitoring progress towards goals. As you've just heard, there are many ways that health IT can be leveraged to identify, engage, monitor, analyze, and improve the health of your patients. Making the most of your technology means improving the identification of patients, improving the quality and convenience of patient care, increasing patient engagement, improving the accuracy of diagnoses, and most importantly, health outcomes, improving care coordination, and increasing practice efficiencies and cost savings. In short, healthcare teams should be leveraging the many aspects of health information technology to manage their hypertensive and diabetic patients. Failing to capitalize on the many ways health IT can be used means not maximizing your return on investment. Healthcare teams owe it to their patients and themselves to ensure they're making the most of the available technology, and the Health IT eLearning Center is here to help. With that, we will turn to questions. Looks like there have been a few that have come in during the presentation, and thank you for that. If you have any questions regarding the information I just covered, or any of MCEDA services for that matter, feel free to put them into the GoToWebinar interface now, and we'll spend a few minutes going through what we have before we wrap up. First question, will we be able to download the PowerPoint being shown now? Yes, it's actually in a couple places. If you look in the GoToWebinar interface in the handout section, it is posted right there. We also have a PDF of the slides posted to the MCEDA website. If you go to the MCEDA website at mceda.org, go to the Resources tab, and then scroll down to Webinars, you'll see a PDF posted there as well. The next question is there any movement to use for transferring data? None exist really today. That is, it is a big problem. The kind of the moving of data, that interoperability that we talk about, which is again kind of the foundation of the Meaningful Use program, and has been one of the biggest hurdles to overcome, is figuring out how to electronically transmit your data to another provider, to that next provider of care. There's kind of two ways to do it. In the past, we've been relegated to get credit for it in meaningful use. So you've been stuck using your embedded direct technology or the peer-to-peer technology that's a part of your EHR. That can be problematic. Really, all of it can be problematic no matter what the solution. But there's a lot of red tape involved, and getting your hands on the appropriate direct addresses to send, it's kind of been a disaster. I totally recognize. Under modified stage 2, some of the red tape got stripped away. That now allows the health information exchanges to get involved. So now the rules have changed, where you can, if you're connected to an HIE, which you probably are if you've been in meaningful use for a couple of years now, you can now use the HIE as long as they're willing to assist with routing the summary of care documents to that end provider. So I would encourage you, if you're stuck using direct or you're not happy with using direct, talk to the HIE that you're doing business with and see if there's a way for them to assist, because the rules have changed and you can now route them through the HIEs and still get credit in meaningful use. Next question, did MACRA discontinue meaningful use? Great question, and the answer is absolutely not. There was some misinformation that came out, some comments that Andy Slavitt, the acting director for CMS, made earlier this year that kind of set the industry on fire. They've kind of had to retract those statements. MACRA does not mean the end of meaningful use. Incidentally, the notice of proposed rulemaking, the next rule, the next revision of meaningful use actually came out last night. It's another 962-page document. So meaningful use is changing. It's actually going to be changing names even. It's no longer going to be called meaningful use. It's going to be called advancing care information. I am just starting to, obviously with it just coming out literally after close of business last night, I have not had a chance to pour through all 962 pages. But we know for certain that this new version of meaningful use, or really meaningful use at its core, even when it changes its name to advancing care information, is still a very big component of MIPS. That's the payment model under MACRA. It's called MIPS. So very soon you're going to be paid from Medicare anyway, not just for, see a patient, bill a code, get paid. You're also going to have to demonstrate that you're taking quality care of those patients in order to maintain your reimbursement levels. So meaningful use is alive and well. It will continue to be alive and well under MIPS and MACRA. Also, a particular note, these changes being proposed will only affect Medicare. It's only the Medicare EHR incentive program. As it stands right now, the Medicaid program is still will still be as it is right now. There might be some changes as the state kind of learns more about all of the changes under MIPS and MACRA. This NPRM, this proposed rulemaking that came out last night, will play a big part in helping the state decide if and when and how they might change their version of the meaningful use program as well. One other question come in. So let's see. Can the identification protocols be programmed right into the EHR? That's a great question, and not one I can outright answer. It depends on your EHR. Some of them are more savvy. That might allow you to build some of the reporting that's required. To work through those protocols, both the diabetes and hypertension one, it really requires a series of queries against your existing database. And so it depends on your report writing ability, and if you've got somebody savvy enough to write those reports, it depends on the reporting capability of your EHR. If you are using an EHR that uses crystal reports, like I know NextGen does, crystal reports can be really savvy, and you might be able to program this entire protocol in so that with a click or two of a button, you can kind of run this protocol against your database. That would be ideal, obviously. A lot of the EHRs probably can't do that, and it might take a series of reports that you run manually to kind of run through those protocols, looking for any patients that have been missed. So again, it just depends on your technology, but I would certainly recommend if you can get this programmed and if you can start using those identification protocols, it'd be great to do it like on a quarterly basis, just to see over the past 3 months if you've failed to diagnose anyone with hypertension or diabetes. Great question. Thank you for that. That is it so far. I don't see any other questions. So I guess with that, we will wrap up for the day. I thank you again for joining us today, and please stay tuned for any additional upcoming webinars. I will be diving headfirst into this new proposed rule that just came out last night. I fully suspect we will be doing some educational webinars on this rule. Possibly not while it's in the proposed stage, but certainly once it's finalized later this year, we will absolutely be doing some educational webinars around that as well. So thank you again, everybody, and I look forward to seeing you again soon.